My name is Dr. Adam Brown. I'm an emergency physician. I'm board certified in emergency medicine. I live here in Washington, D.C. I have been here for 10 years as a D.C. resident. It's almost like being here for a while. But I have a background in also healthcare management and healthcare administrator. I was once a healthcare executive, and up until March, I saw the light. I joined the Great Resignation, also as I call it, the Great Revelation. And I decided to leave the company where I was working, where I was president of emergency medicine, also chief impact officer of one of the nation's largest medical groups in the country, where we saw over 32 million patients a year. My job there was to run the COVID-19 response for the last 2 years. So I have a particular interest in pandemics, in infectious disease, in getting healthcare information out to people that is usable, relatable, so that you can make the best decisions for yourself and impact your community. So when the Blade came to me and said, hey, would you be willing to work with us on a town hall about monkeypox, I was absolutely excited to do it. And at the time I was asked, we still didn't know a lot about it, but I had a sense that things were going to get worse versus get better because we could see the patterns of spread. So I want to frame out the discussion, but before I do that, there are a few housekeeping items. So number one, we are asking people to wear masks. And I see most everybody is wearing masks, so thank you. We are still in the midst of a pandemic. We are still in the midst of a significant amount of spread of BA5. So I'd be remiss not to say thank you for wearing the mask, especially the high-grade masks. If you'd like a higher grade mask than what you have, we do have some there on the back. In addition to that, bathrooms, where are they? They're right around the corner on the other side of that wall. Feel free to get up, move about if you need to. We're here to talk with you for this evening. We are going to be taking your questions, so there's a couple of ways to submit questions to us. One is on the back, we have some note cards that you can write your question down. Those will be fed to me, and then I will be asking some of those questions to our panelists and even to myself, especially with the experience that I've had. We've also received some questions via email, and so what we have done is we've tried to collate some of those questions into bucketing some of them together so that we can ask the panelists throughout the evening. And then in addition to that, remember, we are here to try to give you the best information that we have. Unfortunately, there are some things that are realities for us with monkeypox. The first is we are learning about this new strain and this new manifestation of the disease on a day-by-day basis. Monkeypox is not new. It has been around since the 1950s. However, it moving outside of Africa into other parts of the world and then spreading amongst humans to humans in a fashion that it has been is new. And so we're learning how best to take care of it, how best to treat it. That's number one. Number two, we are woefully, I don't want to use the word unprepared, but we don't have the requisite vaccines around this country and around the world yet to take care and prevent the spread of this disease. That is just being honest. And so when we hear from DC Health, when we hear from the other practitioners, when you hear from me, understand that we are having to do a massive triage event looking at where there is the most disease prevalence now and targeting our resources, vaccine, treatments, and the best things that we have to take care of the disease now. Obviously, we are dependent on other factors, i.e. the federal government, the CDC, and other factors there at play, like manufacturing even of some of the vaccines. So as we start to talk through what some of the plans are, remember that as some of the framing. That is not to make an excuse. That's just to make sure that we all understand the reality of what we're dealing with right now. So without further ado, I'd like to introduce some of the panelists that we have. There we go. So I already introduced myself. One other thing I failed to mention is I'm also a professor of practice at the University of North Carolina, Chapel Hill. Go Hills. If you are from Duke, there's the door. I'm joking, but I am in the MBA program there, or I'm teaching in the MBA program Challenges in Healthcare. We also have Clover Barnes here with us today. She is from DC Health. Clover? Like to further introduce yourself?
So good evening. My name is Clover Barnes. I'm the Senior Deputy Director of the HIV, AIDS, Hepatitis, STD, and Tuberculosis Administration at DC Health. That's a mouthful. We call it HOSTA affectionately. And I am happy to be here with you all. Thank you.
Thank you, Clover. I'm so excited that she is here. When we met the other day, I was like, she's so great to talk with, has so much valuable information. So I'm really excited to hear from you today more. Also, Alshon Bryant, also an amazing panelist. I'm very excited to hear from him. Alshon is a pharmacist. Can you tell us more?
Good evening, everyone. How are you all today? Great. Again, I am Alshon Bryant. You all can call me Al. It's totally cool. I've been with AHF for 10 years now. I'm currently the Strategic Response Team Pharmacist as well as a prep provider for our Temple Hills, Maryland and Capitol Hill Wellness Clinic. So again, thank you all so much for having me, and I'm so happy to be here.
Thank you, Al. And next we have Amanda Carey. She is a nurse practitioner working at Whitman Walker. Tell us more about yourself.
Yeah, hi everyone. Thanks for being here. I'm Amanda Carey. I use she, her pronouns, and I'm a nurse practitioner at Whitman Walker. About half my time I'm seeing patients for primary care, but then the other half I'm managing our sexual health clinic, which is basically our free STI clinic. And so as such, I've been seeing some cases that we'll talk about today.
Thank you so much, Amanda. And we have some hot mics, so sorry about that. So what I wanted to do before we get up here and start, as the whole panel gets up and starts answering some questions, is where are we with this virus? And so the first caveat is when I put some of these slides together, this was at the end of last week. It's already changing. So understand that some of this data may be slightly old, and in the world of infectious disease, as we've learned with COVID, what you may know on Monday may be very different than what you know on Friday. But so far, you can see a map here of the world, and in reality, we're seeing this big, broad spread of this virus to well over 70 plus countries. And that is one of the reasons why the World Health Organization said, whoa, we need to make this a public health emergency of international concern. Now, what was interesting is that the World Health Organization Director General went against the rest of his council, which voted 6-8, to say that this was not a public health emergency. But he said, wait a minute, I'm concerned. I'm concerned for a couple of reasons. One, it is having abnormal spread. Two, it's in a lot of areas of the world where it's not usually located. Three, it's spreading human to human fast. And we're also starting to see it in other populations like children, for example. Now, here in the United States, we're essentially seeing it everywhere. There are a couple of states that are grayed out for reasons some states don't report some of their data. We've learned that as well with COVID. But we're essentially seeing multiple cases around the country, approaching about 3,000 cases. So how does monkeypox spread? And I want to be extraordinarily clear here. Monkeypox is not a gay disease. As I said today on the news, someone asked me, well, what is the issue with this disease? I said, viruses don't discriminate. Humans discriminate. But this virus doesn't. And the fact is a skin-to-skin contact transmission of the disease. So any type of person, any person who has contact that's direct with skin, with a person who has an infectious rash, can get this disease. Secondarily, there are respiratory secretions that can spread the virus. Doesn't seem to be as large as a transmission mechanism, but can occur. Also, touching other items like clothing or bed linens from people that have been previously infected or are currently infected can cause someone to get the disease. And then lastly, we know that monkeypox, as well as other viruses, can spread from the mother to fetus throughout the placenta. So there's concern there as well. Monkeypox can affect all age populations. So it's not a virus just of adults. It's not a virus of just men. We now know that there are 2 children in the United States that had the virus, and there are a few in the UK as well as the Netherlands. So what are some of the symptoms? Now, I will tell you something that someone told me in medical school. Patients don't read the textbooks, or better said, their bodies don't read the textbooks. So just because these are some of the most common symptoms that people may have, that does not necessarily mean that every person is going to have all of these conditions or all of these type of symptoms. But in general, and a recent study that came out by the New England Journal this past week said that about 60+% of people had fever with their rash. So a lot of times if you have fever and rash, you will see, or an abnormal rash, you'll see evidence of monkeypox. Muscle aches, back aches, flu-like symptoms can be some of the hallmarks of the disease. But what we're also seeing, as Amanda will talk about more in detail what we're seeing specifically here in DC, is that these rash and bumps can be very painful. And what's a little bit different than what we've seen in the past with monkeypox is the location of the rashes can be in the genitalia, in the anus, in the rectum, and around the oropharynx or the mouth. So that's something to watch for after someone has some flu-like symptoms, this development of an odd rash. And here are some examples of these different pox marks. You can see some of them are singular, like here on the finger. You can see some look like back knee. Some of them are around the mouth. So it's really a very concerning type of picture that we see because it mimics other type of rashes that people may have. So what are some of the preventive measures in treatment? So one is masks and gloves, especially if we think or we know that someone is infected. There's also the vaccine, which we're going to talk about. There's actually two, but for all intents and purposes, the Jynneos vaccine is the one that most are using right now. The older ACAM 2000 vaccine was directed towards smallpox, used for years and years and years up until the 1970s, but has some other issues which we'll talk about. And then also TPOXX, which is a medication used to treat medicine. And what we'll leave up here for a while, and if you look on your chairs, there's also this same presentation that's here that also has a QR code on it. Please click on that with your phone. You can also take your phone and click up here as well. And this takes you directly to DC Health, where you can register for the vaccine and find out more information, and as well as the CDC. And so as I bring the panel up, thank you, Washington Blade. This is such a great opportunity to talk about this important issue. Also, thank you, DC Health, for what you've been doing so far. We know that resources are limited, so we thank you for getting this information and effort together. So with that, we'll start some of the questions. I've got my phone out, not because I'm checking text messages or TikTok, because I'm getting some questions sent to me live. All right. So, Clover, I'm going to start with you first. Can you guys hear me okay? Because this mic is a little hot. So Clover, give us a breakdown of what's happening here in DC.
So currently, we have about 172 cases here in the district. We are working very hard to make sure that we have resources available for all those folks. We are really working hard to make sure that we are reaching out to everyone who's affected. Our contact trace force has identified and provided vaccines for more than 500 close contacts of those 172 cases. Over 90% of those cases are men who identify as gay, same-gender loving, or men who have sex with men, or bisexual. And to date, nearly 16,000 DC residents have registered for the pre-registration for the vaccination.
So just as a follow-up to that, because I'd laid out before that there was a lot of concern about the lack of vaccines. And that's not necessarily, it becomes a DC problem, but it's not a cause of DC or DC Health. It's because of what was allocated here. So what is DC Health doing now? And this is kind of hot off the press as of 6:30. What is DC Health doing now to try to get more vaccine to people that need it?
So recently, just this evening, we announced that we are going to temporarily go to a one-dose strategy, meaning that everyone will get one dose of the vaccine to start. For folks who had second dose appointments, most of them have been canceled, except for those who are immunocompromised, in an effort to get as much vaccine out to the public as quickly as possible. What studies have shown is that the efficacy of the vaccine, the first dose, is good for 6 months, and we're fairly confident that we can get more vaccine in before the 6 months time clock runs out. And so we are really working hard to get the vaccine out to as many people as possible to prevent the spread as much as possible. And so with that, there'll be more vaccine appointments available later this week.
Excellent. So Amanda, Amanda, I want to go to you because you've taken care of patients that have monkeypox, confirmed cases, not just suspected. Tell us, what are you seeing? And not only just what are you seeing, just how is that different than the way that maybe you and I were trained in school on what we would see with monkeypox?
Sure. Well, I think like you said in the beginning, there is a variety in what we're seeing. I've seen cases ranging from pretty mild to fairly severe. And one thing to note, when I say severe, I'm not talking about people landing in the ICU like we saw with COVID, but I am talking about lesions that can be pretty darn painful, especially if they're near or inside the rectum. So it can be quite painful. But I've also seen, the classic presentation that was up on your slide, starting with fever, chills, flu-like symptoms, swollen lymph nodes, fatigue, followed by a couple days later, the rash and the lesions. On the flip side, I've seen it the other way too, which I think is a little different than what we knew about monkeypox before. I've seen a couple cases with 1 or 2 lesions that were actually mistaken for an ingrown hair for one and acne for other. But since we do have an outbreak right now, I swabbed them, and sure enough, they came back positive for monkeypox. And sure enough, when I called the patient, they started having the flu-like symptoms after the fact. So I'm kind of seeing it before and after. And I'm also seeing a variety of severity in terms of number and location. We are seeing a lot of cases around the genitals, around the rectum, whereas that hadn't been so much the case before. But I've also seen cases that have, spread to legs, arms, torso, face, even inside the mouth. So there is like a variety of presentation there. And the other variety I'm seeing is in terms of pain. Sometimes people are saying, maybe they're a little itchy or uncomfortable, but sometimes they're very painful. And in those cases, I think we'll talk about treatment later, but we do have treatment that we can talk about. One thing before I stop rambling, I'm also seeing co-infections with chlamydia, gonorrhea, syphilis, even HIV. And so, right now, this is a skin-to-skin infection that's spreading a lot through sex. We need to remember those other STIs and make sure that we have testing available.
Because last time I checked, during sex, skin-to-skin contact.
It happens, yeah.
Yeah. So, Alshon, actually, before I go to you, Alshon, I wanted to ask you, Amanda, so you had mentioned testing and you swabbed, and I am hearing from my emergency medicine colleagues from across the country that there's varying abilities to just do the swab and get it tested. What is some of your experience with the testing barriers or successes here in DC?
Yeah, well, first of all, we've come a long way. When we first learned about this, the only testing availability was through the Department of Health, and I know we overwhelmed our Department of Health colleagues, but now there's more commercial testing that's out there. There's LabCorp, Quest, some of the big names in testing, where they have swabs that you can send just as you would any other samples. Now, one thing I have noticed is there's been some problems with LabCorp, and I've heard Quest as well, doing the other STI testing, drawing blood on patients with suspected monkeypox. And we've been in touch with LabCorp about how problematic that is, because these folks need comprehensive STI testing. I know LabCorp is working on that. They're trying to make sure that everyone gets the proper testing, but I think it's an issue that we need to kind of keep on our agenda, the fact that folks need comprehensive STI testing.
But currently, as it stands, it's not like a COVID test that you can go to Amazon or you can go to CVS or Walgreens and buy the test. And there's a pretty extensive algorithm that one has to go through to order those tests, at least depending on your locale.
Yeah, I mean, so I think there's probably a lot of locales that maybe have to, still go through the Department of Health. Maybe Clover can speak more to that. But with LabCorp, it's actually the testing has gotten, much more streamlined. Yeah.
Well, let's shift gears a little bit and talk about the vaccine. So I've mentioned before that there are 2 vaccines. Alshon, tell us about the 2 vaccines and why is one preferred over the other right now?
Sure. So, can you all hear me? Yes? Okay. So the 2 vaccines that are available, one is ACAM 2000, the other is Genios. So let's start with ACAM 2000. So that is a live replicating vaccine, which means that when a patient gets the vaccine, it has the potential to move around the body, and it could also transfer to somebody else, right? So typically with that vaccine, they try to go ahead and cover up the area and make it so that transmission or anything is reduced. That one is a 1-dose vaccine as opposed to Jynneos. Jynneos is a 2-dose series, one 4 weeks after the other. With ACAM 2000, you are vaccinated after 28 days of taking that vaccine. And with that one in particular, at the site of injection, it starts out as a papilla within the first 2 to 5 days, and then over the course of the next 3 weeks, it transitions to a pustule, then it scabs over, and then the scab falls off.
Which is kind of similar to what monkeypox does.
Exactly.
Because
right.
it's similar family.
Right. The other interesting thing about that vaccine, ACAM 2000, is it's a bit barbaric in its administration, because you actually have to prick the skin within 5 millimeters up in the deltoid like 15 different times in order for that vaccine to work properly. Okay. So then we have Jynneos. Jynneos vaccine is, as I said before, 2 doses. That one is given subcutaneously, which is underneath the skin. Considered vaccinated 2 weeks after the last dose. So technically, since you're taking the second dose 4 weeks after the first, and you're vaccinated 2 weeks after the second, it takes 6 weeks to be considered vaccinated, as opposed to the ACAM, where you're vaccinated after 28 days. So those are just some of the differences of those 2 vaccines.
You know, what I find interesting is that the ACAM vaccine, most people don't know about it because we stopped vaccinating people against smallpox in the early 70s. So many of us, people who are over the age of late 40s, 50s, may have the scar on their left or right arm that sees the little marks. I see some heads nodding and shaking, not giving away age or anything like that. They're talking about parents and grandparents who are seeing all that kind of stuff. But no, so there is a question about how much immunity is conferred by those vaccines that may be for populations that are a bit older who may have had it, or let's say laboratory people who deal with smallpox that are getting those vaccines. Do we know how much immunity that may be conferred by those other vaccines if they got them back in the early 70s or before?
So I do see that for people who already have the smallpox vaccine, if it's not within the last 3 years or so, it's encouraged to get it again during this outbreak so that you have proper coverage.
And that's right. And there is some kind of immunological thought that there may be some protection, but like with most vaccines, at some point in time, you need some type of booster with most.
Absolutely.
I want to go to, so we've talked about how do you prevent it, we've talked about what are the things that you see. So now let's talk a little bit about treatment, and I'll start with you and then want to go to Amanda. So we have TPOXX, which is one of the medications. Tell us a little bit about what it is, how do we use it, and then what are some of the issues that we have with getting it to people? And Amanda, I think you can probably take that last part.
Absolutely. I'll pass the torch. So yes, with TPOXX, that medication is a 200 milligram capsule, right? And so you have to take 600 milligrams every 12 hours for 14 days. So technically you're taking 3 capsules every 12 hours for 14 days. That medication is on the United States strategic national stockpile. So there is a stockpile of medication that the U.S. can send to cities that may need it for different things, such as this type of outbreak. So TPOXX is one of those. There are a few other medications that are available through the national stockpile, but TPOXX is definitely the one that is preferred that we're trying to get out to everybody.
And Amanda, what is the issue with just giving it and making it available to everyone?
Well, it's, because it's stored away in our national stockpile, it's not something that can be prescribed to your local pharmacy. It actually has to be ordered directly from the CDC. We're lucky at Whitman Walker. We worked very closely with our Department of Health colleagues, got on the phone with our DC Department Health colleagues and the CDC to procure a stockpile of this medication for Whitman Walker, but that, that's not happening everywhere. And I think it's, on a bigger scale, we need to make that more available. Because I think what I'm hearing is that there's not a lot of access there. I've heard from many folks that are not in this area that their providers just kind of say, listen, there's nothing we can do. We just have to tough it out, which, I think we have the medication. It would be, I think it's important to get it out there.
And we're much more likely to be better situated here being in DC than in many other parts of the country.
Yeah.
Can I just add one thing there? So we do have some TPOCs available through the Department of Health. We have a process by which providers can request it. We cannot distribute it to patients directly. It has to go to your provider. So if you do have monkeypox and you do need TPOCs or want TPOCs, please contact your provider. Your provider can order it directly from us, and we can get it to them within the same week for most times.
And I'll also add really quickly, so if there's anybody who may have a severe allergy to any of the components that is in TPOCs, that being gentamicin, ciprofloxacin, or egg protein, is highly encouraged that they not take that medication. So they want to put that out there as well.
As before we switch gears, I wanted to mention something about vaccines, and it's particularly important with the news that came out in the last couple of days, and that is, we have 2 children that have been diagnosed in the United States, again indicating the skin-to-skin contact transmission. But vaccines aren't approved for children yet, and so that is a gap for us that we need to recognize, that children under the age of 18 are not eligible for vaccines unless there is some type of authorization released by, I think, the FDA or the CDC. Please don't quote or record that part. But from my understanding, that is not yet approved by the CDC, except under very, very special circumstances. So I want to talk about stigma. So I am asked that question all the time, because this disease right now, from what we know based upon who has been being tested, has been found within the gay community, the trans community, men that have sex with men. So, Clover, I want to start with you. What are some of the biggest concerns that you have, especially considering your role and your background with Ryan White? What is your concern about the potential for stigma associated with this virus?
So we don't want to stigmatize anybody at any time for any reason, right? So stigma can have significant effects of shame and hopelessness, and it can also prevent people from seeking and getting the care and treatment that they need. With that said, DC Health has always been a great supporter of and advocate for all our LGBT community. And while right now the monkeypox is specifically affecting gay, bisexual, and men who have sex with men, it's not uncommon for the disease to cluster within specific populations, and that in no way represents any fault of that population or that community. So it's important that we don't stigmatize the people who have it right now just because they have it, right? At this moment, the cases that we're seeing are predominantly in that community, which is why we have been focusing our limited resources in that community. It's the best way for us to try to pause the outbreak and to quell the spread that is happening right now, and to keep people as safe as possible.
I'd like to ask that, I wrote something in the Washington Blade, came out last week, about how we can't repeat the issues that took place with HIV and AIDS, with monkeypox, because the risk that you run is that if you don't focus your messaging on the community where there is the most prevalence, and say, well, everybody can get it, and all resources should be for everyone, when there are limited resources, you actually risk the virus to spread. So what is the balance? Amanda, you're seeing these patients. What's the balance between making sure that the message is crafted and targeted to the right people, but also making sure there's broad-based awareness?
Yeah, I'm not sure I have an easy answer for you, because it's not an easy problem. I think monkeypox or no monkeypox, we as a society have a lot of stigma and discrimination against folks in the LGBTQ community, anything to do with sex. I mean, just baseline, if we wanted to back up to sexual health in this country, we've got a lot of way to go. And so we're kind of, this is on top of, issues that are already stigmatized. And so I think it's important to just reinforce the message that, the The virus doesn't know your gender, it doesn't know your sexuality, it knows you have a body and it wants to affect the body. What's happening now is people are moving in their communities and social networks, and that's where, you know, we're seeing the spread, but it's only a matter of time until we see that kind of affecting more and more people. So everyone needs to be aware that this is something that can help them, that this is something that can impact them, while at the same time making sure the resources, the vaccine, the treatment gets to the people who are most affected right now.
And Alsha, what are your thoughts? Because you've certainly been in the HIV community working with that. What are some of the risks to outcomes if there is stigmatization?
Yeah, stigma is always something that has impacted, you know, those outcomes. With my experience, a lot of people experience barriers to care, so many barriers to care that are kind of parallel with the stigma associated with them getting into care. I think that the more we stigmatize things, the more people who may need it feel like they might not need it, you know, because we're kind of like carving them out of the equation. And because we're carving them out, they're going out into impact and affect other people. So the more that we do that, the more that we will see an injustice in care as it relates to treatment outcomes.
I think it's a great point. You know, one of the concerns is, of course, if you focus the messaging so much on one community and you're not doing broad-based surveillance in other communities, you miss the potential of it growing and spreading in other communities, and then other people thinking, I can't get it, and yet they're spreading it from person to person to person.
Exactly.
And that's exactly what we saw happen a lot within HIV. So we've talked about what DC Health is doing. And when you compare what DC Health is doing with many other cities, it's really a good job compared with what, when you take it into consideration with what resources we have available. What's happening across the river or across the border? What's happening, Clover, I'm going to put you on the spot. What's happening in Virginia? Because a lot of the people that work and live here in DC, meaning they're here on the weekends or they're working here, they're interacting with folks in DC. So what's happening in Arlington, Alexandria, Montgomery, PG County?
So I can't speak for any jurisdiction besides the district.
I knew that was coming. I knew you were going to say that.
But we do know that our borders are fluid and people work and play across the borders back and forth. So we do have a regional work group where we work very closely with the state health departments in Maryland and Virginia to try to make sure that our strategies align and that we're communicating and discussing all the issues that are affecting our residents across the border. With the way that this vaccine strategy has been rolled out, the vaccines that we get are reserved for district residents. It's based on your residency and the number of cases in each jurisdiction. So right now, the vaccine that we have is for district residents. But we actively are meeting with Virginia and Maryland about their strategies and how we can coordinate and make sure that we are all doing the best we can for our constituents.
So we've talked about the vaccine, we've talked about the treatment, what are some of the signs and symptoms and how it's differentiated from what we learned back in the day in school. What happens if someone believes they have the virus or they see a lesion? Amanda, what's your recommendation?
Yeah, so if you think you have the virus and you have an active like rash or lesion, we can test that. And so reaching out to Whitman Walker, the Department of Health, your own PCP, ideally they can test it now that, commercial labs are involved in the testing. But definitely just come on in, get it tested. If you're having those flu-like symptoms and you're worried about it but don't have a rash or a lesion, unfortunately at this point we can't test it. We can't test it before there's a rash or a lesion, so it's something to keep an eye on.
But you could have COVID.
Yes, that was, you stole my punchline there. Yes, please, no, it's okay. But please test for COVID too, because if those flu-like symptoms in that first stage can be very similar, so yeah.
So I want to talk about, you've heard me say now multiple times that one of our biggest issues with combating this virus is resourcing. So what can we do locally and federally to advocate for more resourcing? I'll put you on the spot, Clover. I'll try and start you. What can we do to advocate?
What can we do to advocate? I think it starts here. I feel like it starts with having a conversation with the community, addressing the elephant in the room, addressing questions, and let's kind of talk about ideas, I'm so grateful to DC Health and Washington Blade for putting something like this on. I feel like these are the type of things that help rally people behind the cause, behind an initiative to help propel and move something forward. So I think it starts with like community engagement like this, you know?
Yeah, I mean, I think everyone should feel empowered to reach out to lawmakers, reach out to your members of Congress, reach out to, you know, even the White House. I think use like the local community resources to really band together and call for more action.
And I'll just close this out by the best thing you can do for us right now is to be informed, is to register through the pre-registration site to get yourself vaccinated, and to make sure that you're visiting monkeypox.dc.gov to get all the latest information for what's happening and make sure you can protect yourself as best you can.
And one more thing, to help spread the word, tell your friends, tell your family, you know, to take this seriously. Because the more we talk about it, not only in this type of forum, but outside of these walls, I think the more educated people will be.
So we have a number of questions that have come in from the audience via email, as I mentioned. I've pulled some of those and some of the comments that we've already made. But I also want to give you the opportunity to ask some questions as well. Steve in the back has a few questions. I'm going to run around with the mic. I'm going to hold the mic so that we're not having to clean the mics off and things like that in between people. So I'm going to first, while we're getting some of these things together, I'll just ask, is there a concern with current messaging that will create stigma in which straight people avoid casual interactions with gay and bisexual men? Amanda, I'll ask you that question.
Yeah, I mean, I think getting back to our earlier comment, of course there's a concern because the stigma, there's already underlying stigma there. And so I think, again, kind of getting that message out that anybody with a body can get this under the right circumstances. And I think it's also important to, you know, empower people too, because, you know, spreading the message that, oh, everyone can get it without also telling people that we also have the tools to prevent it, to treat it. I think that's also really important because we do have those tools. We just need to make them more available.
Yes, so we need more of them. Question from the audience, is there data about the percentage of infections not occurring from sexual contact?
So I'm going to defer that one to one of my DC Health colleagues who could be seen afterwards about how it's actually being transmitted. There we go, Dr. Mangala.
Yes, my name is Anil Mangala, I'm the state epidemiologist. So our team does all the contact tracing, all the assessments of all the cases that we have. Out of the 172 cases, we have at least about 5 cases that have been other than sexual contact. So there is, again, as we had discussed earlier, it's skin-to-skin contact, and so, you know, we've seen that also. 3 of the cases we had lesions on their tongue, in their mouth. They had no sexual activity. Some of them even had condoms on, even then they got it. So it is very clear that this is just not a, you know, sex act that's going to cause them to get infected. It is the skin to skin. It is, like we said, respiratory secretions, meaning during kissing, hugging, and things like that. So again, that close contact is very important.
And, you know, just to add on that, excellent, thank you. To add to that, if you're only testing gay men in STI clinics, guess what? You're probably going to get a lot of gay men with STI or having sex with the disease. So there's a selection bias that has been occurring, and until you get a more broad-based surveillance, it's just like with COVID in the initial early days. You know, you're going to get some selection bias. Here's a question. Individuals are being asked intimate information on the number of partners, if they've had sex for money, if they're going to sex parties. What is DC Health doing, Clover, this is to you, doing with the data? And how much is protected? And why can't we just simply self-certify that we're eligible for these vaccines?
So I'm going to answer a little bit and then maybe kick it back to Dr. Mangala here. But that information is de-identified, so it's not linked to the person who submitted that information. We use that information in aggregate to understand what's happening with the population and to identify the risk as you're pre-registering or registering for the vaccine. So that's not information that we can tie, like Dr. Mangala said he had sex with 5 people. That's not what, sorry, Dr. Mangala. That's not how we're tying the information back, okay? So it's an aggregate group of information.
So we've heard there have been, this is probably due to, or I can answer this question too, there's been 0 deaths associated in the United States. How many hospitalizations have there been nationwide? But we'll go first to DC. Do you know the number of hospitalizations here in DC?
The hospitalizations we've had are more due to pain management rather than anything, or rather than the severeness of the disease.
And that's been the same response in, around the United States as well. There have, of course, been deaths associated with monkeypox in Africa. This is another reason why we need to focus our efforts on controlling and preventing diseases in other places around the world. We're all connected. If someone catches monkeypox after their first vaccine dose, do they still need a second dose? Alshon, I'll go to you, and then Clover.
If they catch monkeypox after the first vaccine dose,
Will they need a second?
So CDC recommends that if you've been exposed within the first 4 days to that you get the vaccine, right? Anywhere between 4 to 14 days, the symptoms are, you would still possibly get the monkeypox if you were exposed, but the symptoms would go down. And that is the extent of what I know about it.
Well,
So
that's kind of the extent of what the CDC is saying. It's a little bit of a gray area right now.
Right.
Clover, your thoughts?
I would just say that we do not recommend that you get the monkeypox vaccine if you've had monkeypox.
That's right. So what I have always said, even with COVID, and as we learn more, that is today, that is the recommendation today, as we go further, as we learn more, that recommendation may change. So this is important for you to always pay very close attention to what the recommendations are, but also to talk to your primary health care provider. You may have a special circumstance, immunocompromised state, be taking a medication that may cause you to have an immunocompromised state, where there may be a reason or rationale for you to get a vaccine. So this is an important one. It's a gray area right now. So Alshon, correct, Clover, correct. I mean, not that I'm the arbiter of correctness or not, but that is what we are learning so far. All right. And also raise your hand if you have a question, because I'd love to go back to other folks too. Okay, you first. Great.
Thank you all so much. Thank you, DC Health and Blade. Andrew Zappel of the DC Center for the LGBT Community. A lot of the focus has been now on prevention through vaccines or treatment. But we know that there are not enough vaccines right now. You can walk to any CVS and get one, that there's going to be a delay. And my question is to you all is what should these communities most at risk be doing to prevent potential spread of the vaccine and to prevent exposure to it while they're waiting potentially to get a vaccine? And second question, there are 2 vaccination sites right now, I Street and Georgia Avenue. One is a little inaccessible, I feel, for a lot of people I've talked to. How is DC Health making it so there might be more vaccine clinics, more accessibility, so people can have access to vaccines in areas that are able to get to?
So what can we do to prevent this disease? Because we know there's not enough vaccines. And then number 2, and I'll come back to you as well. And then, okay, great. And then number 2, it seems that this is not so accessible, our vaccine sites. So let's take question 1. Amanda, to you, since you're seeing patients, what is your best advice for preventing this while we're waiting for vaccines and treatments?
Yeah, so I think, I've definitely heard advice similar to how we were talking about sex during COVID times, of which we are still in. So I know there's been ideas like, limit partners, have more video or phone sex, mutual masturbation, there's apart. Yeah, so there are these ideas, but I do want to, and like right now, because there's not enough vaccination, these are tools to consider, but I do want to be clear that this is a vaccine preventable illness, and in an ideal world, we actually get that access out so that people can have the sex that they want to be having. So yes, talk about it with your partners, talk with your partners about have they gotten a vaccination? Do they have any symptoms? Kind of use some of these COVID strategies. But really that should be like a stopgate. Like I really want to see the vaccine available so people can have the sex lives that they have the right to have.
Agree. Others? We can all clap for that. And Clover, to you, other comments about preventive measures while we're waiting for the vaccine? No, okay. Clover, to you, and what about the choice of location for vaccine sites? Can you give us, and the inaccessibility of those sites?
So, hot off the presses, there is going to be another site opening later this week on the other side of the river. And so that will come live later this week. I'm going to give a shout out to my colleague Patrick over here, who's responsible for that effort. And more vaccine appointments will go live later this week as well.
So this next question, I can take the start on it, anyone else can opine. With COVID variants on the rise, what is the most effective way to educate our communities about monkeypox and ways they can get access to resources? Really simply, we put those QR codes up there. They're on the back of the info sheets that each of you have. The Washington Blade has done an excellent job of highlighting monkeypox, ways that you can get resources. So please make sure that you're utilizing those resources, checking up frequently to protect yourselves and protect others, especially because I know how it happens. You talk with your friends, you have conversations with your friends, you talk about what do you know, and this is the best way to get the accurate information out there. Your influence network is the best way to get information out to people. It just needs to be accurate. So use some of these trusted sources as ways to get out information. So secondly, and this wasn't in the question, but they talked about COVID variants. And there's a question of, will there be a lot of variants associated with monkeypox that could there be a need for further boosters? The fact is right now, because of spread in monkeypox in the past as being relatively low, there's not been a huge amount of variation that has occurred with different strains. Although there are a few strains right now of monkeypox, and one that's here in the United States is dissimilar from the past. So this is going to have to be a wait and see. But what we do know is the more quickly a virus spreads, the more likelihood it has to mutate. And so if we can do everything that we can now to reduce down the spread of this virus, we can reduce down the chances of monkeypox mutating. It is not COVID though. COVID-19 or the coronavirus spreads so rapidly, so quickly, and is so efficacious at getting us sick and also having asymptomatic spread. The potential is there for mutation quickly, and we're living through wave after wave of different mutation. That doesn't seem to be the case with monkeypox. But again, this is based upon the information that we know now. Other questions from the audience? Oh, yes, sir.
So I wanted to elaborate on, I get this question all the time regarding the monkeypox virus and the COVID-19 virus. And are we going to see new strains or new linkages, and then of course the effectiveness of the vaccine. So the key here, if you look at the molecular part of the two viruses, they are viruses, but they're very different. The COVID-19 virus is a single-stranded RNA virus, and when that occurs, it has a high possibility for mutations. It's not stable. And so that's why it mutates much faster, and as discussed, because of the spread, it's more opportunity for it to mutate, because as it lives in the body, that's extra time for it to change. Now let's look at the monkeypox virus. The monkeypox virus is a double-stranded DNA molecule at a molecular level. That molecule is very stable, and there's rare opportunity for it to mutate just on its own. And the fact that it's not going to mutate, the vaccine we're using currently would be very effective. As a matter of fact, 85% or higher effectiveness. And because you're not going to see mutations, or mutations may be rare, that vaccine is going to hold effective for quite some time.
Thank you. So going back to a question about stigma and even the messaging from DC Health, if this isn't a gay disease, why is DC Health's vaccine registration site asking questions about that you must be gay or a bisexual male? Clover?
So right now we're prioritizing the populations who have the highest impact. And so that is a public health strategy that when one community has a higher impact of something, you dedicate your resources to that community to try to stop the spread and to keep it from going further. And so we will continue, as long as the resources are scarce, to have a strategy by which we're going to the communities who are most affected.
So I had a question about testing. Well, let me back up. You had said that we're targeting the community that's most affected right now. But if we're not doing broad-based surveillance or testing, it's hard for us to know. How many tests, and this was a question that we had earlier, how many tests, what is our testing capability? What is our surveillance capability here in DC?
So now that the public health labs or the other labs, the commercial labs are on board with doing the testing, you can go to your provider and get tested. Anybody can get tested. It is not just communities who are highly impacted. If you have a susceptible rash, you can go see your primary care provider and they can test you. Unfortunately, we can only test the lesions, as was said earlier, so there's not like a blood test you can draw, or they can't swab your cheek or anything like that. But they can swab the lesions. You can also go to an urgent care, or if it's severe and painful, to an emergency room to get tested there as well.
You can't just walk up to a Quest or a LabCorp.
No, you
Okay.
need an
I wanted to
urgent
make sure that was clear, because sometimes there's an assumption, like in the past with COVID testing, you could go to the tent, or you could go somewhere, wherever they were doing the testing. Not the case for this. It needs a provider's order. I want to go, Alshon, to you. Question about what are some of the side effects of the Jynneos vaccine? So, we don't need to go into the side effects of ACAM 2000 because 99.999% of people are not getting it. What are the side effects of the Jynneos vaccine?
Side effects would include tiredness, fatigue, things of that nature. Sometimes people might have like a mild fever. That may be a side effect, but it won't last too long. We're talking about Jynneos. Yes. So yes, injection site reaction. So any warmness or itching of the injection site, that's also one of the side effects. So fatigue, tiredness, mild fever, injection site reactions are some of the key side effects of the vaccine.
So this question is from an ID doctor, and the question I think is a good one, because as an ER doctor I face the same concerns, and that is why are we being told, and why are patients being told to contact or connect with the CDC for information about this virus? I mean, we did it here. We said, hey, here's information for you in the CDC. But as we have learned, sometimes the CDC and the Department of Health has challenges with communicating effectively to patients, to providers, on the best way to seek treatment, to get treatment, to avoid the disease. So the question here is, why are patients being given zero information on treatment and prescription options? And as a provider, I'm left kind of sitting on my hands, looking incredibly stupid and uninformed. I feel that sometimes. I completely understand.
Well, I'll start out by saying that's unfortunate. We do have weekly calls with providers in the district about monkeypox and the response. We invite any provider in the district to join those calls. They're very highly medical and scientific, so they're for providers only. But we talk about how to get TPOXX, what the labs are doing, any questions people have about swabs, and so forth. If you see me before you leave, I can get you the information to make sure you can get on that weekly call. We also, I feel like sometimes the information is so new and so novel that not everybody has the best information, and sometimes CDC has the best source of information for what's happening. But as the response evolves, we do update providers weekly with the information that we have and how we're responding to the response. I actually lead those calls.
And that's, I think, a really good point, because I know, having a spouse that works within the government too, sometimes folks in the government say, oh, well, we have all these calls with stakeholders, but people don't sometimes know how to engage with the government or with the DC Health. So just remind us again, like, who is open to be on some of these calls? Who do you want to see on some of these calls? How do they access it again?
Any doctor, nurse practitioner, PA who is seeing patients who might have monkeypox or have questions about it, we invite you to come on and get onto the call. It's for any prescriber in the district.
And most of the information is, how do you access treatment? What are the latest policies? What are the latest protocols? Where are there gaps? Where do we need
A place to ask questions if they have them, so that they can provide the best and safest care to their patients.
Comment.
Excuse
And
me?
to receive comment?
Yes.
Okay, good.
There's
So-
a question.
Oh, yes, good. I didn't exercise today, so I'll turn it on.
Okay. Thank you so much for this. You mentioned earlier that immunocompromised individuals could get their second shot still, and that their appointments have not been canceled. I think you said all the ones that weren't immunocompromised were canceled. How are you defining immunocompromised? What information do you have on intake that would give you that information?
Excellent question.
That is a good question. So one of the intake questions asks about your immunocompromised status. It includes everything from HIV to having arthritis, being on steroids, anything that can compromise your immunity, and we ask you to self-report that. So if you report it when you register for the vaccine, then that's how we're determining that information.
So another question, and over to you. What is DC doing for individuals who test positive who don't have the resources to isolate? Maybe they're unhoused. What is DC doing for them?
That is a great question because we don't have a lot of resources on that one. So we will deal with those cases on an individual basis and try to do the best we can to move them through the other resources that are available in the district.
And just to piggyback on that, it's not just, folks who are unhoused. I mean, you have to isolate for 2 to 4 weeks with this. So folks need to be out of work for that amount of time. Not everyone has a job that's flexible enough to allow that. And so that's just another area where we need to come up with ideas on how to support folks.
My question has to do with people who are immunocompromised. And I want to know how effective the vaccine is for those people.
Great question. Come this way. So the initial, I'll start talking and then I would love the good doctor from DC Health to chime in. So the initial efficacy of the vaccine for general populations is around 85%. But when we're looking at folks that are immunocompromised, my assumption would be less.
I'm Dr. Kim Summers. I'm the Chief Science Officer for DC Health. I've been on the Monkeypox team as well. So I don't think we have great data because this is still fairly new. We're repurposing this vaccine that was studied for smallpox, and the idea is that it should work for monkeypox since they're so closely related. In general, like principles of vaccination, a lot of vaccines tend to not be quite as effective in people who are significantly immunocompromised. But in addition, when you're talking about HIV, there can be a difference if your HIV is well controlled. You have a reconstituted immune system versus if you have advanced HIV/AIDS. There can be a big difference, and we know that from other vaccines. So that's what I suspect will be the case here, but I think it's early and we're gathering the data as we go.
Thanks. Yeah, the initial studies that you see on the CDC website, they're touting 85%. But, I want to remind people of a couple things. One, we get a flu vaccine, different vaccine, but just talking about principles, immunology and vaccines, it can change from year to year because the vaccines change. This is a different strain than what we've dealt with before, so that could also change things. And then I think your point is a phenomenal one about what is immunocompromised. Immunocompromised is not everybody has this immune system who has the label of immunocompromised. It's variant from person to person. This goes back to why it's so important to be linked up with your healthcare provider and really have those conversations. Next.
I'm Jason Crichton, and my question is, and perhaps this is an epidemiology question. First, thanks to DC Health and the Blade for hosting this. In light of DC Health's moving to an interim one-dose strategy, is there more information upon how robust the efficacy of one shot of Jynneos vaccine may be within a 6-month window versus 2 doses?
We'll start with you, Clover, and looking for the other person.
I'll just say that we, in our calls with other health departments around the country and trying to do the best thing we can right now with the resources that we have, the research has showed that the efficacy stays effective for 6 months. I don't have a specific percentage for you right now, But following in what New York City and other health departments around the world have been doing is the best way to get as much coverage out as possible with the resources that we have right now. I just want to add one more thing. We do have a health alert notice that went out on Friday for providers who may not be on the calls that we have weekly. That should have gone to every licensed provider in the district.
Hi, thanks very much for the forum. I'm not sure if I understood correctly. Did you, and I apologize, I don't know your name from the health department.
I'm Clover.
Thank you.
Like the little green things that grow on the ground.
Did you just confirm, I just received an email from the health department stating that there will not be a second dosage scheduled at all. Is that what you were just referring to a second ago?
Mm-hmm. Only for people who are immunocompromised will they get the second
I'm not immunocompromised, and it says, given the rapid, this is 10 minutes ago, given the rapid increase in the cases and the limited supply of the vaccine, we have decided the most urgent priority is providing the first doses of the vaccine to high-risk residents without, at this time, a future date planned. I'm not sure, is that what you stated? Because that wasn't clear.
Yes.
Yep, that's what I stated earlier.
For everybody, not just immunocompromised.
Only the immunocompromised folks are getting the second dose. Everyone else's second dose will be delayed, not discontinued.
Just remember that part of the rationale just is there is likely a need for well over 100,000 doses of vaccine. And what is the number that the city was allocated? Somewhere around?
I believe we have somewhere around 12 to 14,000.
And so I think the concern was giving that second dose, you're now only protecting a relatively small group of individuals, when really, based upon some of the evidence, that there's a 6-month window that you would have for protection with a singular dose.
Actually, this is just to piggyback on all of that. As someone that is not technically eligible, but still concerned about exposure, with this new strategy, and we were also at the press conference last week when Dr. Nesbitt talked about kind of like how you all were receiving it from the federal government. With this new strategy, when do you feel that the eligibility will open up, just prospectively?
That's a good question, and I can't really say right now. We are hoping that we're going to get more doses of the vaccine towards the end of August to early September, a larger quantity, but we're not sure about that right now. That's not outside of our control. But as we get more doses of the vaccine, the eligibility will evolve as we get enough that we can move it. We encourage everybody to pre-register. It's not just open to the target population right now, it's open to everybody. And as the eligibility changes, then more vaccine appointments will be available.
I'm heading over this way next, but as I'm going, there was a question about someone who had a family emergency. They were supposed to have their shot, but because of a family emergency, they have to leave. What happens to them? Is there a way to reschedule these appointments?
Oh, that's a great question. I'm going to turf that to Patrick over here. And if you're walking that way, I'll walk this way. How about that? We'll double team it.
Thanks, Clover. So if somebody misses their appointment, they can let vaccinatedc at dc.gov know. They will go back into the queue to receive a future invitation to be schedule their appointment. They just can't reschedule because we've already moved that dose on to someone else.
Question?
Yeah, I have a couple. Is there any way to forecast, like COVID, when there may be a home test kit available?
No, not at this point.
Secondly, what are you doing on sex apps like Grindr and Scruff or whatever?
That's a great question. We actually are working on something to target there actually right now. So our plan is to have some more targeted social media out there coming up soon.
I want to ask this question over to you, Amanda. What are, and this also Clover, and also all of you, how are we and how should we be addressing some of the concerns for racial bias as it's concerning with not only access to vaccines, but to treatments, and also just provider care, because that is clearly an issue here in the city and around the United States. Amanda, I'll start with you.
Yeah, I mean, well, we know we have baseline racial disparities in health, and so, it makes sense that, with a new health issue, we're going to have to really address those disparities and focus on them. I think You know, I think it's getting the resources to the right places. So I know there's going to be a vaccine location opening up in Southeast to really focus in on our Ward 7 and 8 community. I think we also have to, you know, reconcile with like a baseline kind of lack of trust in healthcare that kind of stems from a lot of these racial inequalities and racism. And so I think, again, not an easy answer because this is really a problem that goes a lot deeper than any one issue, but it's something that, you know, we ought to make sure that resources are in locations that reach everyone and get the message out to everyone.
I'll just add that we have done some clinics, targeted clinics in different organizations to try to kind of meet people where they are. So you may have heard in the press conference that happened last week where Dr. Nesbitt spoke about a clinic we have with an organization named Us Helping Us. We have a couple of other more targeted clinics planned for communities that are harder to reach. And so those are not public clinics. They're targeted towards the folks who are seen at those locations and who may have less access to other locations to really try to even out some of the disparities.
And Alshon, your thoughts?
Listen, I'm in 100% agreement with what you said, Amanda. So that's all I have to say about that. Yeah.
Okay. Good evening. Joseph Reeves here, pronouns they, them. Also a proud resident of Ward 5 here in Washington, D.C. And back to the point that was said about isolation, because this also meets kind of like the D.C. housing crisis. Because if you're living in D.C., especially if it's D.C. proper, it is highly unlikely that you own your own home where you can just isolate and be by yourself. So I just wanted to say that piece as a commentary in connection with the isolation. But my actual question is that we have heard a lot about co-infection. And kind of like my concern as someone who is vaccinated, boosted, and even after I was boosted, still contracted COVID. And then even kind of like with the accessibility around comprehensive like STI testing, and this is, I guess, this is kind of like more for public health providers, but how even though we've seen so much of DC open back up, so many of our public health providers still are not doing walk-up testing for people. So that means a lot of the people that need the testing the most are not getting access to it. So I'm guessing, to put it in a nutshell so that I'm not dragging the evening, when it does come to like those co-infection questions, what are we going to do to possibly lift the age requirement for getting that second booster? Because right now it's like you either have to be over 55 or you have to be immunocompromised. And for me, as a Black queer person, I consider myself immunocompromised to everything simply because of my social location.
So just going back, now we're still in the midst of another pandemic, and so we have to consider that while we're dealing with COVID, because it's definitely not gone away, to your point, we also have monkeypox. So just as an aside, what are we doing from a testing strategy with monkeypox? We already talked about the vaccine strategy. What are we doing also to make sure that we are getting the vaccine to the right people who need it in the right locations around us? And I'm talking about not the monkeypox vaccine, I'm talking about now COVID vaccines.
So we have COVID centers in all 8 wards around the district. And so you can visit a COVID center and get a vaccine if that's what you need. The questionnaire, I believe, does have a question for if you're immunocompromised, and you can check that box and you can get the COVID vaccine sooner than being 55.
Question here.
Can you talk about what populations it's recommended that folks not get the monkeypox vaccine? I've specifically had someone who has eczema, who has a skin condition, sort of understand that maybe it's recommended they don't get the monkeypox vaccine, they'd still like to. So just sort of your sense of like what types of individuals or what conditions might make you say, I shouldn't get the monkeypox vaccine based on the science we have right now.
Al?
So I know about the severe allergies. I'm not well versed in that question that you have there, so I can definitely field it to someone who may be more familiar.
Yeah, I wonder if there's some confusion between the ACAM and the Jinios kind of embedded in that question, because For the ACAM, there are definitely people who shouldn't get it, folks who are immunocompromised, because that vaccine can replicate and you can actually get symptoms. And if you're immunocompromised, you're more likely to get that. I think for the Jynneos vaccine, aside from, history of severe allergy reaction to vaccines, I think there's not the same limitations.
Absolutely right. So the issue with ACAM is, as you mentioned, it's a live virus that can replicate. That's the reason why the old school smallpox has to be covered, because it can move around. So if you're on immunomodulating medications, it can even allow that virus to even spread more. People that are getting steroids in the eyes, the virus can attack the eyes. So there are a lot of potential negative outcomes that can be associated with smallpox. Smallpox vaccine, ACAM 2000. But just to be very clear on something here, smallpox is not monkeypox. Smallpox, they're ugly cousins. Like smallpox is a very ugly cousin, but what is it, like almost a 30% death rate associated with it. So when you're making the risk assessment of do I get the ACAM 2000 or do I take monkeypox, the answer is very clear. I take the ACAM 2000. Wait, did I mistake? If there's a potential you have smallpox, then ACAM 2000 is the way to go. But with monkeypox, with a very low likelihood of death, with a low likelihood of other type of issues associated with it, there's a much higher risk associated with ACAM 2000 of having complications associated with the vaccine. But that's one of the reasons why that vaccine is not broadly available, is not even available in most cases. That's why the focus is on Jynneos. Any other commentary to that? Good? Okay, next question. Oprah's job was hard, folks. Let me just say
This is about the Jynneos vaccine. Nothing in the package insert for that says anything about contraindications with eczema.
Perfect. Any other comments or questions? I've got a couple.
Sorry, I don't mean to be a greedy bitch. I got two more. One of the best things that happened in the 2.5 years with COVID is there was a central website, I guess it was HHS or CDC, where you go in and plug in your zip code and be directed to local resources for testing and treatment. Do you foresee that at all, and would it be CDC again?
That's a good question. I'm hoping it doesn't get that far, but if I'm being honest. But if it does, then we would work towards those resources.
One more question.
Yep.
I absolutely love how you partner with iOS, iPhone, and did that exposure notifications. Literally every time I go to the gym, I get one after. Do you see a potential where you could piggyback on that, since so many of us already have it, and alert us when we may have been exposed to?
We don't have anything about that right now either. Hopefully we won't get that far.
Good question here I have, I'll get to you next, is as we are, actually two. One is as we are ramping up the outreach to providers, and we talked about this a little bit, but how can we make sure that we have some level of consistency with the information flowing out? Like, what is the cadence of information so that providers can come to expect, on this date there'll be updates coming from DC Health, and therefore I need to then get information out to my patients a few days following. What is the cadence of information? How frequently is it coming out?
So we do a health alert notice when there's a significant change or some alert that's coming to the way that people are going to treat or prescribe around the disease. Currently, we've been doing the weekly calls to just be kind of in touch and consistent with the communication, because things are so new and have been changing so rapidly in order to keep up. The Monkeypox website also can give you information and can also help you get in touch with us if you need more specific information from a provider perspective.
Thank you.
I own two businesses here in DC. We see probably 2,000 to 3,000 people a week that are in the LGBTQ community. I think during COVID, the DC government did a really good job of providing us with information on an ongoing basis to provide actual materials, physical materials, posters, things that would allow us to communicate as well as we could, or at least consistently. Sometimes we maybe felt like we would be more aggressive with the messaging than even DC government would be, but at least there was a consistent baseline of information. Is there anything like that set up yet? Are there resources for me, materials for me, other than a QR code, which we already have posted, but is there anything else?
Sure, there are some handouts as well as palm cards that we can get you. We can get you things that you can post. This gentleman sitting right here, Mr. Torres, can get you what you need.
In light of that, I had a question that came through about what should facilities, non-healthcare related facilities that have just the general population mixing and coming to it, do to protect their patrons, to protect their staff members from contracting this disease? The words they use, or the things that they use here with apartment buildings, gyms, or restaurants.
So I feel like in this age of COVID, all the things that we do to sanitize and keep things clean are the same things that we need to do. You know, COVID hasn't gone anywhere with the envision of monkeypox here with us. We need to continue to be vigilant about our hand washing, wearing masks. All those good things help protect us from all the germs, but mostly from the ones that are most contagious. So if we continue those practices that we started during COVID, I think we'll be in good shape.
And I want to ask Clover you a question. You're on the hot seat. A couple of rapid fire. What's DC Health planning to do to increase testing capacity? We've talked about the public-private partnerships, but what else are you planning to do?
So testing, any provider can test for it. It's a swab. So it is not something that we need something special. You need a special medium or you need a special whatever for. Any of your providers that you go see can test for monkeypox.
Next question is, are there plans for mobile clinics, or not mobile testing sites, or mobile vaccine clinics for monkeypox?
Right now, the resources for vaccines are so scarce that I'm not sure we could staff mobile sites and the local clinics and support other things. They're very rare. You need to understand that we have probably more than anybody else in this region right now for vaccine, and we don't even have nearly enough. We only have about 10% of what we would project to need. So there's not a way that we could staff mobile sites and mobile clinics and all those things at this point.
Is information available in multiple different languages, since we have such a large community where people don't speak English?
We do. On the website, it's translated in Spanish, Amharic, all different languages. We have English and Spanish here with us tonight, but if you're interested in other languages that aren't there, we can get those for you.
And then one other one, I'm going through my emails, so the questions I'm getting. It's transmissible, monkeypox we've already mentioned is transmissible via like linens and of course we've already talked about skin to skin. Now that we have children that have had this disease, what are the plans to keep children safe as they go back to school? And I'll just tell you, I'm concerned about when kids go back to university as well.
So that's a little tougher. So we don't have vaccines and such that are available for children right now. So we are still on this, protecting yourself, keeping away from if you have a rash, don't let that rash touch a child, type of thing to protect yourself. It's still skin to skin, so that's skin. Babies have skin, kids have skin, everybody has skin, right? So it's skin to skin. So we want to do our best to keep those children protected.
All right, there's another question right here.
So thank you very much. I think part of my question was about the language thing. I think most of the time, DC is the most diverse city that I've ever lived. We have a huge percentage of immigrants in the city. And most times, even though we live here, it is always assumed that if we speak
there are enough vaccines in this stockpile. It's not some new exotic, situation that's come down the pipe. So I'm sorry if I'm a little bit upset.
No, we are too.
Out there, and just also want to, thank you for this forum and appreciate all the leadership you're exercising.
No, I would echo that. That frustration is really great. As we started talking Friday at the making the decisions of who could and who couldn't get the vaccine first and second, that type of process of triage is all occurring because we don't have the resources, and that is an uncomfortable, unfortunate, and unnecessary reality that we're facing. So I think your point is spot on. I don't work for the DC government, so I can echo it and say yes, absolutely. But I think we can all say that too. Yes, Amanda?
I just wanted to echo that in terms of I don't think it's acceptable, but even to back up the fact that this has been spreading in different West African countries, Central African countries, without having the vaccine appropriately available there, I think that goes a lot further back than what we're dealing with now.
Absolutely.
None of it is acceptable.
So we are at time, so I'm going to wrap up. And I didn't ask you guys this question, but I'm going to ask you, so buckle up. No, it's pretty easy. You got one opportunity. What is the last thing you want folks here left with? What is the high-level thing you want them to know about the disease, about the treatment, about the vaccine, about the response? Alshon, I'm going to start with you.
Like I said before, I think community education is very important. Having the conversations with family and friends so that we can all help educate and become aware of what's going on together, and we can actually do something about it as a community.
Yeah, and I echo that, and I guess to piggyback off of our last conversation is really, I think it's important that we're all advocates and we work together as a community. I think we need a more robust federal response that we've been getting, and frankly, a global one. And so I just want to make sure everyone feels empowered to talk to their lawmakers.
Clover?
And I'm a nurse by trade, so I'm just going to appeal to everybody to be an advocate in your own health care and in your own health, and to be knowledgeable about the things that are affecting you, and to be able to use your voice to speak up to get the things that you need and want for your health care. I want you to be patient with us at the health department, because we are doing the very best we can with the resources that we have to get them out to you guys, and to make sure that we are keeping our residents as safe and as healthy as possible. That's the mission of the health department. That's what we're trying to do in all our actions and efforts. And we thank you all for coming out today.
Last thing, hold on. Last thing I want to say is again, I appreciate this panel. I really enjoyed meeting each of you last week and talking with you through this. I have learned so much from this. The thing that I want to share with each of you is that what I have learned, not only as a health communicator, as someone who's been an executive in a company, now starting my own company, you are the most important link in your community as an influencer. People who you are connected with, your friends and your family, you have a sphere of influence. And when you get information that can not only protect yourself, but that is accurate, you have the ability to impact others. And your word becomes very important. So many of us don't listen to our doctors. We don't listen to our nurses. We don't listen to our healthcare providers, but we listen to Kim Kardashian and those people on TikTok. Okay, I'm joking, but not. But we listen to folks within our influencer network. So it's so extremely important that for all of you who have shown the effort tonight to listen to this group, to follow this information, to take this back to your communities, to continue to stay up to date, because you are an influential individual and you are going to protect lives by learning more about this disease. So I thank each of you. I have left our names and things up here. Follow us on Twitter, email us, slip into our direct message, ask us questions. We are going to still be here. We are still going to be here. Okay, you get the last question. This is a fidgety group, I can tell. This is like
23
no.
23 mini pages of notes, and thank you for giving me all this fodder. I have one quick question for you. What percentage of the vaccines that are distributed are made by Jenios?
Well, right now, all of the vaccines that is because that's the only one available.
Thanks for sitting.
Yes. All right. Well, thanks everyone. Have a sit. We'll talk offline. Thanks everyone. I really appreciate it. Stay safe out there. And if you have any questions, we're still up here. We're happy to talk to you the last few minutes.